Dr. Abhishek Kumar is Associate Professor, Department of Medicine, NSMCH Patna. Is Secretary, Clinical Cardio Diabetes Society of India. He is EC member, Lipid Associate of India, Bihar chapter, and is EC member of RSSDI, Bihar chapter. I request Dr. Abhishek Kumar to proceed with the presentation.
Thank you, sir. First of all, I would like to thank Dr. Akash Singh, sir, and the team for this opportunity. And also being the secretary of the society, I thank you, sir, and Dr. Anil Kulsrestha, sir, for introducing the CCDSI hall and CCDSI session in this conference. My topic is hypertriglyceridemia in Indians. And when is the situation when the treatment beyond a statin is required? So topic is a concise. The statement is concise, however, topic is not. So I would try to stick to the statement only. We all know that in our country and in South Asian populations, we are having atherogenic dyslipidemia, means the small dense LDL along with the high triglycerides and overall the higher level of the non-HDL cholesterol. If we look at the epidemiological data, the total cholesterol more than 200 ranges from 20 to 30%. And non-HDL, if we take more than 130, then it is about 50%. And triglyceride more than 150 is about in the 30 to 40% of our population. And our population is also having low HDL. So high cholesterol, high LDL, non-dense LDL, and high triglyceride with low HDL. Every bad possibility of the lipid combination is there in our country. This slide we come across on every lecture of the lipid. We can see here that in the third one, here is the triglyceride assessment by the ICMR India have a study, in which we can see that the most of the country is having around 40% increase in the triglyceride level. So triglyceridemia, hypertriglyceride level is there in our country in more than 40% of the populations. So this is the unique feature in our society. So we have to deal with all these things. Now, if you look at the studies that regarding reducing the hypertriglyceride or the triglyceride level is directly not beneficial in the ASCVD trials. However, it has been seen that the triglyceride level is directly associated with the insulin resistance, glucose intolerance, diabetes, adiposity, and the inflammation. And the molecule which is responsible for all these is the high level of VLDL and chylomicrons, which we call the remnant of the triglyceride. So the consensus is that in case of the persistent high level of triglyceride, if the patient is having at risk for ASCVD or the patient is having ASCVD, you have to target the triglyceride also. So the latest Lipid Association of India guideline and even the European Society published this year has marked the plasma triglyceride more than 150 in the fasting and more than 175 in the non-fasting stage as a risk modifier. So in the person, you have to look in a totality. If the person is having other risk factors, this high triglyceride level increases the chances of ASCVD. So we have to look into this blood picture of the patient as a whole, not only for the triglyceride level. So this is the protocol at which the triglyceride has to be targeted. On the right side, we can see that in the low risk patient, if there is no risk factor, then the target LDL cholesterol is less than 100 and non-HDL less than 130. This non-HDL includes the VLDL and the chylomicron component. Thus, our aim of targeting the triglyceride level become fixed. Increasing from the right side to left side in the moderate risk, high risk, very high risk, and extremely high risk, you can see there is a target level of LDL-C and non-HDL cholesterol. In the extremely high risk group, the target LDL cholesterol level should be less than 40, and even our Lipid Society of India is saying that it should be 0 if it can be achieved. And of course, the non-HDL target cholesterol target should be less than 70. So this will serve our purpose of targeting the triglyceride level. Thus, the approach should be the complete assessment of the patient regarding the metabolic diseases, including the diabetes and the other ASCVD factors. And always remember that if triglyceride level is more than 1000, it is a high risk for pancreatitis. And even for the 500 to 1000, we should be very, very cautious. So beyond 5000, there should not be any confusion in the treatment for the triglyceride. But below 500, you have to assess the patient as a whole. The four main factors, this is also applicable for any lipid disorder, that is lifestyle modification, treatment of the underlying causes. Again, for triglyceride also, the first medicine remains the high dose of the statin. And then thereafter, the other molecules like the fibric acid derivative, niacin, omega-3 fatty acids have the proven role. Now the newer agents has been approved and they are coming in the market. We will discuss a few about these molecules also. In dietary component, it is the same as we target the LDL cholesterol. However, complete restriction of fat is not indicated even in the extremely high risk group of the patient. You have to choose the combination of MUFA and the PUFA, and of course, we all know that the oil should be of two types. One must come from the nuts, the other, like the mustard oil or the coconut oil, can be used. So the oil must contain the MUFA, PUFA, and the high N3 upon the N3 upon the N6 ratio. The trans fat should be minimized as minimum as we can go. So we are again focusing on the traditional Indian cooking and the traditional Indian oil to achieve all these things. And definitely this will help in LDL and triglyceride also. For the exercise and the lipid, we know that even the moderate intensity physical exercise leads to the favorable changes in the lipid. We must consider one thing. If the patient is having high dose of statin, the patient may get the muscle soreness while doing the severe high level of vigorous exercise. So that caution has to be taken into the mind. And the current guideline also advocates the practice of yoga, which is time tested in our culture. And possibly it is also going to improve the lipid conditions. So just focusing on my point, what can be the beyond statin? Few slides I have made that is very practical. One is the niacin. We should remember that the high dose of niacin, about 1.5 mg to 2 mg per day, is effective in decreasing the triglycerides, not less than that. So if you choose the niacin and give at this dose, this reduces the TG level by 40% and also raise the HDL level. It is also effective in slightly reducing the LDL level and lipoprotein A also. The spelling is incorrect of the lipoprotein A. The precaution has to be taken. Niacin has multiple side effects. Usually the flushing and itching is there at the first doses, at first few doses. But the worst is that it may cause the chemical hepatitis, and it has been associated with a modest increase in the insulin resistance. So in diabetic patients, the diabetic control must be watched. Regarding omega-3 fatty acid, we regularly use in our practice, even in our homes also. But again, we have to remember the dose. At high doses, more than 4 gram per day, it is effective in reducing the triglyceride. The low doses do not affect the lipid level. However, it has been demonstrated to be protective in the cardiovascular disease, probably due to its anti-arrhythmic property. Its ultra fine molecule, that is icosapent ethyl molecule, is nowadays prescribed. That contains more of the EPA but less or the no DHA. So the chances of the simultaneous LDL cholesterol increase is less. But always we have to remember that we have to count the capsule, how many capsule of the omega-3 fatty acid we are going to get these effects. Now, other things, the simple thing like the metformin. Metformin reduces the weight and, of course, controls the diabetes and causes a reduction in the triglyceride levels. So, metformin, where possible, however, still it is a first drug, but whatever dose is possible, you must admit it. Ezetimibe, of course, it has a slight effect, but it has effect in controlling the triglyceride level. So if a statin is not effective, what can be given? So these slides we are discussing. Regarding the newer agent, the one is olizarsen that is indicated as an adjunct to diet to reduce the triglyceride level in the familial chylomicronemia syndrome FCS. It is indicated at the 80 mg subcutaneous weekly and has been shown to be effective at the 6 months. So this is for reserved for the severe hypertriglyceridemia not responding to the traditional therapy and the statins. In last year, the FDA also approved an ApoC3 directed small interfering siRNA molecule, and that has been approved again in the FCS. The other molecule which are in the pipeline are the angiopoietin like 3 inhibitor, apolipoprotein C3 inhibitor. So this is the list in the lower panel, and the second lower panel we can see the latest molecule which is in the pipeline that has to be given in a severe level of triglyceride not responding to a statin and the other traditional approaches. So finally, this is the slide that is given by the Cardiological Society of India in its update in 2026, and this is in accordance with maximally it is in accordance with the Lipid Society of India and the ECS 2026 guideline. Here we can see that in case of the triglyceride more than 500 to 1000 in the right side panel, you have to do intensive lifestyle, very low fat. Of course, zero fat is not advocated. Fibrates, omega-3, even the newer molecule saroglitazar that has been approved by the Indian government in management of dyslipidemia, especially the hypertriglyceridemia. And the other things, as there in the slide, time is very less. The last line about the pregnancy. In pregnancy, we see that triglyceride usually increases, and even the total cholesterol increases. Practically, no drug is approved in pregnancy. So we have to go for the dietary intervention only, and this will remain the mainstay in the treatment of hypertriglyceridemia during the pregnancy. Omega-3 fatty acid and bile acid sequestrant can be given. One thing I missed in the slide, that is the fibrates. We are using it. It is a time-tested molecule. So fibrate are one of the molecule which is not mentioned in this slide that is used beyond the statin for the control of hypertriglyceridemia. Thank you, sir.
Thank you, sir. That was an excellent presentation. Any questions from audience?
I've got a couple of questions. One is, what is the role of saroglitazar? So that is one of the very commonly used drugs, basically in India. So fibrates with statins will have a higher toxicity, and once we use the omega-3, how long we should wait for the results? For the after how long do the triglycerides drop? How much time we should test for triglycerides after initiation of the purified APA?
Uh, Sir, regarding the how long will it take? Usually, it is the 6 month from where the effective decrease occurs in the case of the omega-3 fatty acid. The second question, whether we should prefer fibrates over omega-3 fatty acids with a statin. We know that, sir, fibrates, especially fibrates, is not having any ASCVD benefit. So, depending upon the side effect profile, if the patient is not tolerating, and of course, many patients do not tolerate. So, in that case, we can go for omega-3 fatty acid, but again, the dose has to be kept more than 4 gram per day to get the effective reduction. The first one I missed.
Saroglitazar.
Saroglitazar. Sir, saroglitazar basically in India and the Japan and the Asian countries, we use for the MASLD or metabolic component of the fatty liver disease, and definitely it is going to reduce the metabolic syndrome component and the triglyceride level. At present, especially in case of hypertriglyceridemia without MSLD, it is indicated only for the severe hypertriglyceridemia more than 500 and especially more than 1000 in case of the patient is given pancreatitis and all other things. So it can be used. However, in clinical practice, since this molecule is being used for multiple purposes, and many of the patients, apart from the genetic syndrome or the familial syndrome, the high triglyceride is usually associated with the metabolic components. So starting it earlier is also beneficial.
Yeah. Good morning, sir. My
Good
name is
morning.
Dr. Ankur Rawal. My question is about the niacin and the hepatotoxicity. Sir, is it all or none phenomena, or is it dose dependent?
Sir, it is dose dependent and universally up to 2 mg per day, 1.5 to 2 mg per day, it is not occurring. So we don't have to worry about. But sir, if you look at our profile, the level of MSLD and all these liver baseline liver disorders is more in our community. So it is the Western study. In Indian study, we do not have what level it causes the chemical hepatitis, but by FDA, it has been approved up to the 2 mg per day, and beyond that, there is a chance of chemical hepatitis. So it is dose dependent more.
Sir, one quick comment about the use of metformin for the diabetic patients. Like as such, almost all diabetic drugs which can lower the glycemia, they can be useful for the triglyceride. In fact, like those diabetic patients who are having the A1C more, first we should try to control the A1C, and then probably the triglycerides can be managed well.
Completely, sir. Because the risk factor has to be and the associated disease has to be controlled first. So diabetes, if you are going to control by any means, that is going to reduce the triglyceride level.
Same is true about hypothyroidism.
Yes, sir. I have mentioned in the slide also. In hypothyroidism, triglycerides is raised. So we don't have to go for triglyceride first. The metabolic component and the endocrine has to be corrected first.